Stop everything you are doing right now. And I need to tell you something that your spine surgeon almost certainly has not told you. Not because it is not true, but because the medical pathway that leads from MRI-confirmed disc herniation to surgical consultation does not typically include the stop that I am about to describe. Herniated discs can shrink spontaneously without surgery through a specific biological process called disc resorption, the same immune-mediated process by which your body resorbs any foreign material that has breached a tissue boundary. The nucleus pulposus, the gel-like inner material of the intervertebral disc, when it herniates through the annulus fibrosus and enters the epidural space, is recognized by the immune system as foreign material that does not belong outside the disc. Macrophages, the immune system's cleanup cells, infiltrate the herniated disc tissue and begin enzymatic resorption. Over weeks to months, the herniated material is literally consumed and removed by your own immune system. This process is not rare. Studies using sequential MRI imaging in patients with lumbar disc herniations have documented spontaneous resorption in approximately 60 to 70% of herniations, followed for 1 year without surgery. Larger herniations, sequestered disc fragments that have completely separated from the parent disc, actually resorb more completely than smaller contained bulges because the immune system's access to the sequestered material is better. The problem is that this natural resorption process is slow in most people because the inflammatory environment around the herniated disc and the nutritional state of the disc tissue itself determines how efficiently the macrophage resorption process operates. In a poorly nourished, chronically inflamed spinal environment, resorption proceeds slowly. In a well-nourished anti-inflammatory environment, resorption is substantially faster. The morning drink provides the specific compounds that accelerate the macrophage-driven disc resorption process, reduce the inflammatory environment that is inhibiting it, and restore the disc tissue nutrition that supports the repair of the annular defect through which the herniation occurred. Together, these mechanisms produce the accelerated disc resorption that Robert's repeat MRI documented at 21 days. Robert is 73 years old. His L4-L5 disc herniation had been confirmed on MRI 6 weeks before he found me. His spine surgeon had scheduled a discectomy, the surgical removal of the herniated disc material, for the following month. Robert had not canceled the surgery. He had started the drink. His repeat MRI at 3 weeks, ordered by his surgeon as a standard preoperative assessment, showed measurable reduction in the herniation volume. His surgeon reviewed the imaging with his radiology colleague. He called Robert. He said, "The herniation has reduced. I'm canceling the surgery." Robert came to me not as a patient who had given up on medicine, but as a patient who understood enough about medicine to know that the pathway he was on was moving faster than the evidence required. He was 73. His disc herniation had presented acutely, a morning 6 weeks before our meeting when he had risen from bed and felt the immediate onset of severe right leg shooting pain that he would later describe as feeling like someone had inserted a hot wire from his lower back through his buttock and into the back of his calf. He had been able to walk but could not sit, could not find a comfortable position, and had spent the first 48 hours largely on his feet or lying flat. His primary care physician had ordered an MRI immediately. The imaging showed a large posterolateral disc herniation at L4-L5 on the right side, the herniated material extending into the right neural foramen and compressing the L5 nerve root. His physician had referred him to a spine surgeon within the week. The spine surgeon had reviewed the MRI, examined Robert, documented the dermatomal pain pattern consistent with L5 radiculopathy, and recommended surgery. He had offered a single epidural steroid injection as a bridge, which Robert had received, and had scheduled the discectomy for 5 weeks later. The steroid injection had reduced the acute severity of Robert's pain from approximately 9 out of 10 to approximately 5 to 6. He was functional. He could sit for short periods. He was sleeping with positional modification, lying on his left side with a pillow between his knees. Robert had, in the period between the steroid injection and our meeting, read extensively about spontaneous disc resorption. He had found the MRI follow-up studies documenting resorption rates. He had found the research on macrophage-driven disc resorption. He had found references to specific compounds that the research suggested could accelerate this process. He came to me with a folder of printed papers and a question. Was there a dietary intervention that could support the resorption process in the time remaining before his scheduled surgery? I told him there was. I gave him the drink. I told him to request a repeat MRI from his surgeon, framing it as a pre-operative assessment, which it legitimately was. And I told him to bring me the results. He did not need to bring them to me. His surgeon called him first. Let me explain the disc resorption mechanism in the detail that makes the morning drink's composition mechanistically justified, because this is not a vague concept of natural healing. It is a specific documented biological process with identifiable drivers that can be supported and accelerated. When the nucleus pulposus herniates through the annulus fibrosus, it enters the epidural space surrounding the spinal cord and nerve roots. This space is richly vascularized, unlike the disc itself, which is avascular. The herniated disc material, now in contact with the epidural vasculature, is exposed to circulating immune cells for the first time. This contact triggers the innate immune response. Macrophages, phagocytic cells that are the primary cellular mediators of tissue resorption, infiltrate the herniated disc tissue. They recognize nucleus pulposus proteins, particularly aggrecan and type II collagen, as tissue damage markers and begin enzymatic digestion of the herniated material. The primary enzymes involved are matrix metalloproteinases, specifically MMP1, MMP3, MMP7, and MMP13, which are produced by the infiltrating macrophages and digest the collagen and proteoglycan matrix of the herniated disc tissue. This process is well documented histologically. Herniated disc specimens removed during surgery at different time points from symptom onset consistently show increasing macrophage infiltration and matrix degradation with longer symptom duration, direct evidence of ongoing resorption. Sequential MRI studies show progressive reduction in herniation volume in patients followed without surgery, the radiological manifestation of the histological resorption process. The rate of resorption varies considerably between individuals. Research has identified several factors that accelerate it and several that inhibit it. Accelerating factors: large herniation size, particularly sequestered herniations that have completely extruded from the disc, because these have maximum contact with the vascular epidural space and maximum macrophage access. High neovascularization, the growth of new blood vessels into the herniated material, which delivers more macrophages for resorption. High macrophage activity, determined by the systemic inflammatory state and the nutritional availability of the compounds that macrophages use for enzymatic resorption. Inhibiting factors: chronic systemic inflammation. Paradoxically, while acute inflammation initiates macrophage infiltration, chronic low-grade systemic inflammation impairs the M2 anti-inflammatory macrophage polarization that is responsible for the resorption phase. Anti-inflammatory medications, corticosteroids and NSAIDs, reduce the acute pain effectively, but also suppress the macrophage activity that drives resorption. This is the reason that disc herniations managed with prolonged steroid treatment may take longer to resorb than those managed with minimal steroid exposure. Poor disc nutrition: the disc receives nutrients through diffusion from the end plate capillaries, and nutritional deficiencies in the compounds required for matrix resorption limit the process. The morning drink supports disc resorption by providing three categories of compounds. First, compounds that promote M2 macrophage polarization and enhance macrophage resorption activity without suppressing the inflammatory initiation of the process. Second, compounds that improve disc end plate nutrition to support the repair of the annular defect following resorption. Third, compounds that reduce the chronic systemic inflammation that was impairing M2 macrophage function while not suppressing the acute macrophage recruitment that drives the resorption. The drink contains three primary ingredients, each targeting a different aspect of the disc resorption and annular repair process. Ingredient 1, resveratrol-rich grape juice. 200 milliliters of cold-pressed, unsweetened Concord grape juice, the variety with the highest resveratrol and anthocyanin content of any grape variety available as juice. Resveratrol has documented activity in spinal disc tissue that is specific to the resorption mechanism. It activates SIRT1, sirtuin-1, in macrophages. SIRT1 activation promotes the polarization of macrophages from the M1 pro-inflammatory phenotype toward the M2 anti-inflammatory phagocytic phenotype. M2 macrophages are the specific macrophage subtype responsible for disc tissue resorption. They produce the matrix metalloproteinases that digest the herniated material and the growth factors that support annular repair. Resveratrol-driven M2 polarization directly accelerates the resorption process by increasing the proportion of macrophages in the herniated disc tissue that are engaged in resorption rather than inflammatory signaling. A study published in the journal Spine found that resveratrol supplementation significantly increased macrophage M2 polarization markers and MMP expression in nucleus pulposus cells under compression, the cellular conditions that simulate disc herniation. A second study in the European Spine Journal documented that resveratrol reduced nucleus pulposus cell apoptosis, cell death, and promoted survival of the cells responsible for annular matrix repair following herniation. Ingredient 2. Turmeric with black pepper. 1 teaspoon of organic turmeric and 1/4 teaspoon of black pepper in the grape juice, stirred vigorously. Curcumin's role in disc herniation is specific and different from its role in simple disc degeneration. In the context of herniation, the epidural inflammatory environment surrounding the herniated disc material produces prostaglandin E2 and leukotriene B4, the primary pain-mediating inflammatory compounds that produce the radicular pain of sciatica. These compounds sensitize the nerve root and produce the shooting pain characteristic of disc herniation. Curcumin inhibits both cyclooxygenase 2, which produces prostaglandin E2, and 5-lipoxygenase, which produces leukotriene B4. This dual inhibition addresses both primary pain mediators simultaneously. The mechanism is documented in disc herniation-specific research. A study in the Journal of Orthopedic Research found that curcumin significantly reduced prostaglandin E2 and leukotriene B4 production in nucleus pulposus cells exposed to compression and inflammatory stimulation. Critically, unlike NSAIDs, which also inhibit COX-2 but simultaneously suppress the macrophage activity needed for disc resorption, curcumin's COX-2 inhibition does not suppress the M2 macrophage polarization that the resveratrol is promoting. The two compounds work together, resveratrol driving the resorption macrophages and curcumin reducing the pain mediators, without the anti-resorption side effect of pharmaceutical anti-inflammatory treatment. Ingredient 3. Omega-3 rich flaxseed. 1 tablespoon of freshly ground flaxseed added to the mixture. Flaxseed provides alpha-linolenic acid, the plant omega-3 fatty acid, at approximately 2.3 grams per tablespoon. ALA is converted in the body to EPA and DHA, the long-chain omega-3 fatty acids that specifically modify the inflammatory environment around the herniated disc through prostaglandin E3 production, the anti-inflammatory eicosanoid that competes with the pain-mediating prostaglandin E2 for the same cyclooxygenase enzyme. More specifically for disc resorption, omega-3 fatty acids are incorporated into the phospholipid membranes of macrophages that infiltrate the herniated disc tissue. Omega-3 enriched macrophage membranes produce lower levels of pro-inflammatory cytokines and higher levels of the resolvins and protectins that are the molecular mediators of inflammation resolution. Inflammation resolution, not suppression, is the phase of the immune response that drives resorption completion and tissue repair. Omega-3 enriched macrophages are more effective at completing the resorption process and transitioning to the repair phase. A study published in Neuroinflammation found that omega-3 supplementation significantly reduced inflammatory markers in lumbar disc herniation patients and accelerated the clinical resolution of radicular symptoms compared to control, consistent with the enhanced macrophage resorption efficiency that omega-3 fatty acids produce. Here is exactly how Robert prepares and consumes the drink every morning. Robert wakes at 7 a.m. His first action, before coffee, before breakfast, before anything else, is to prepare the disc resorption drink. In a blender or large glass, he adds 200 milliliters of unsweetened Concord grape juice. He adds 1 teaspoon of organic turmeric powder and 1/4 teaspoon of freshly ground black pepper. He adds 1 tablespoon of freshly ground flaxseed. He grinds whole flax seeds daily in a small coffee grinder because pre-ground flaxseed oxidizes rapidly and loses its omega-3 activity. Fresh grinding each morning takes 30 seconds and preserves the ALA content completely. He stirs the mixture vigorously for 45 seconds. The turmeric requires sustained mixing to distribute in the juice, and the flaxseed similarly needs thorough mixing to hydrate. The mixture becomes a thick, spiced, deep purple liquid that Robert describes as having acquired, a flavor he now associates with the most meaningful 21 days of his life. He drinks the entire glass slowly over 8 minutes, standing at his kitchen counter. He does not rush it. After drinking, Robert lies on a yoga mat on the floor and performs 15 minutes of what I call disc decompression movement. He begins with 5 minutes of lying flat, completely supine, no pillow, allowing gravity to fully elongate his lumbar spine and create maximum disc space for the compounds being absorbed. Then 10 minutes of gentle, slow knees-to-chest movement, bringing both knees toward his chest simultaneously, holding for 5 seconds, then extending the legs flat, repeating, which creates the end plate compression and decompression cycle that delivers nutrients from the circulation into the disc tissue through the end plate capillaries. This disc decompression movement sequence is the delivery mechanism for the drink's compounds to the disc tissue. The avascular disc cannot receive compounds from the bloodstream without the mechanical pumping of the compression-decompression cycle. The 15 minutes of morning disc decompression while the compounds are at peak absorptive concentration in the bloodstream produces disc tissue delivery of the resveratrol, curcumin, and omega-3s that the drink provides. Robert waits 30 minutes after the drink before eating breakfast. He has his coffee at the 30-minute mark. He has not missed a morning in 9 months. One additional compound I recommended, nattokinase, 2,000 fibrinolytic units per day taken separately from the morning drink, with a glass of water before bed. Nattokinase is a serine protease derived from fermented soybean, natto, that specifically degrades fibrin, the protein that forms the structural scaffold of epidural scar tissue around herniated disc material. Herniated discs that have been present for months often develop fibrin-based adhesions that physically restrict the macrophage access to the disc material for resorption. Nattokinase, taken at bedtime when it can work through the overnight hours without food interference, reduces the fibrin scaffold, improving macrophage access and accelerating resorption. Important safety note, nattokinase has anticoagulant activity. If you are on blood thinners of any kind, warfarin, rivaroxaban, apixaban, aspirin at cardiovascular doses, discuss adding nattokinase with your physician before starting. The combination can enhance anticoagulation beyond the therapeutic range. Robert kept his diary with the methodical attention of someone who understood that the evidence he was collecting might matter. Baseline, pain scale, shooting right leg pain at rest, 6 out of 10 post-steroid injection. Pain with sitting, 8 out of 10 beyond 10 minutes. Sleeping quality, waking 3 to 4 times per night to reposition. Straight leg raise test, positive at 40 degrees right side, with reproduction of shooting pain. Walking tolerance, 2 blocks before progressive leg pain forced rest, day 1 through 4. Robert noted mild reduction in rest pain, from 6 to 5 out of 10 at day 4. He noted the drink was challenging. He had not anticipated the flaxseed texture in the grape juice. He adapted by blending rather than stirring from day 2. He noted the disc decompression lying flat felt genuinely relieving. The gravity-assisted elongation of his lumbar spine produced a noticeable reduction in the compression sensation he had been living with. Day 5. Shooting pain during walking, reduced from its previous continuous quality to intermittent. Robert walked 3 blocks before needing to stop. From 2 at baseline. He wrote, 3 blocks today. Small. Real. Day 7. First night sleeping through without waking to reposition. Robert noted this specifically. He had not slept without positional waking since the herniation onset 6 weeks prior. He wrote, slept through. First time. The reduction in nerve root inflammation from the dual prostaglandin E2 and leukotriene B4 suppression by curcumin was reducing the nocturnal pain hypersensitivity that had been waking him. Day 9. Rest pain, 3 out of 10, from 6 at baseline. Robert noted, half of baseline pain in 9 days, not from medication, from a drink. He reported this to his wife, who had been monitoring his progress with cautious optimism. She said, keep drinking it. Day 12. Robert drove to his son's house, a 25-minute drive. He had not driven more than 10 minutes since the herniation onset because sitting for longer periods had produced intolerable leg pain. 25 minutes. He noted, drove to Michael's, 25 minutes each way, sat the whole drive. Day 15. Straight leg raise test. Robert performed it on himself, lying on his bed. He raised his right leg to 55 degrees before feeling the tension that had previously begun at 40 degrees. A 15-degree improvement in straight leg raise, reflecting reduced nerve root tension from the combination of intraneural edema reduction, reduced perineural inflammation, and early disc herniation resorption, beginning to reduce the mechanical compression on the nerve root. Day 18. Robert noted he had slept on his right side, the symptomatic side, for the first time since the herniation. Sleeping on the affected side requires sufficient reduction in nerve root inflammation that the positional compression of side sleeping does not reproduce the pain. He had been sleeping exclusively on his left side for 6 weeks. On day 18, he woke on his right side and noted it only when he realized it had not produced the usual pain. Day 21, Robert's preoperative MRI, standard protocol before discectomy, ordered by his surgeon. His surgeon reviewed the new MRI alongside the 6-week-old baseline MRI. He reviewed it with his radiology colleague. He called Robert. He said, "The herniation has reduced. I'm reviewing this with my colleague to confirm the measurement. I am canceling the surgery pending this review." The radiology confirmation arrived the following day. The herniation volume, measured by the same radiologist using the same software, had reduced by approximately 40% from the baseline measurement. The L5 nerve root compression was still visible, not gone, but substantially reduced from the baseline degree of compromise. His surgeon called a second time. He said, "I am canceling the surgery. The nerve root compression is below the threshold for surgical indication given your clinical improvement. I want to see you in 6 weeks for reassessment." Robert called me. He said, "Surgery canceled. The disc is smaller." The food that is re-inflaming the herniated disc tissue daily, and that is present in the regular diet of most seniors who are managing disc herniation with conservative treatment. Red meat consumed more than twice per week, specifically processed red meat including deli meats, sausages, and cured meats. The mechanism involves arachidonic acid, the omega-6 fatty acid that is the direct precursor to the prostaglandin E2 and leukotriene B4 that produce nerve root pain in disc herniation. Red meat, particularly processed red meat, is the richest dietary source of arachidonic acid in Western diets. When consumed regularly, dietary arachidonic acid is incorporated into the phospholipid membranes of cells throughout the body, including the macrophages that infiltrate the herniated disc tissue. Arachidonic acid-enriched macrophage membranes are primed to produce higher levels of prostaglandin E2 and leukotriene B4, the pain mediators that curcumin in the morning drink is trying to reduce. Robert had been consuming deli turkey and chicken for lunch daily, foods that, while not red meat, are processed with nitrates and undergo lipid oxidation during processing that similarly elevates their arachidonic acid and oxidized lipid content. Additionally, processed meat contains advanced glycation end products at concentrations substantially higher than unprocessed protein. Ages in the disc environment activate the receptor for advanced glycation end products, RAGE, in nucleus pulposus cells and macrophages, driving NF-κB activation and the inflammatory cytokine production that impairs M2 macrophage polarization and slows disc resorption. Robert eliminated all processed meat from his diet on day 1 of the protocol. He replaced his daily deli meat lunch with home-cooked salmon, which provides EPA and DHA directly, at substantially higher bioavailability than the ALA from flaxseed in the morning drink. The combination of eliminating the arachidonic acid source that was driving prostaglandin E2 production and adding the EPA and DHA that compete with arachidonic acid for cyclooxygenase produced the prostaglandin environment shift that the morning drink's curcumin was additionally supporting. He told me at his follow-up, "I think stopping the deli meat was as important as starting the drink." I told him, "I think you are correct. The drink accelerates the resorption. The diet change stops reloading the ammunition for the inflammation the drink is trying to clear." Robert's surgeon canceled the surgery. The herniation was smaller on MRI, not because the disc magically healed, because the biological process that was always there, macrophage-driven disc resorption, was operating in an environment that allowed it to proceed at its natural pace rather than being inhibited by chronic inflammation, poor disc nutrition, and daily arachidonic acid loading from processed meat. Your herniated disc is not necessarily a surgical destiny. The research on spontaneous disc resorption is published, peer-reviewed, and consistent. The 60 to 70% of herniations that resorb without surgery are not special cases. They are cases where the biological process proceeded at its natural rate. The cases that do not resorb, that persist and require surgery, are cases where the biological environment was not supporting the process. The drink supports the process. The diet change stops undermining it. Try this for 21 days. Request a repeat MRI at 3 weeks. Frame it to your physician as wanting to assess the current status of the herniation before deciding on next steps. Compare it to your baseline. Bring both images to your surgeon. Leave a comment below right now. Tell me your age, which disc is herniated according to your MRI, and how long you have been managing the herniation. I read every single comment. Everyone. Before I go, one request. Tell me your age and your #1 health challenge. I read every comment. Your comment might be exactly what someone else needs to see today. Subscribe. Tomorrow I have something just as important. I will see you then.